welcome and good morning from Hospital Ludwigsburg. My name is Andreas Wannhoff. I'm the first author of our study, Endoscopic Vacuum Therapy for Treatment of Boerhaave Syndrome, a multicenter retrospective analysis. I'm working at Hospital Ludwigsburg in Germany as an interventional endoscopist. Today with me is Dörte Wichmann. She's the senior author of our article. Maybe Dörte, you want to introduce yourself real quick as well.
Yes, thank you, Andreas. Yes, my name is Dörte Wichmann. I'm a visceral surgeon at the University Hospital of Tübingen, and I'm an interventional endoscopist too. Yes. And can you tell how the idea of the study was born?
Well, yeah, that's actually interesting how the study came to place. And it was, I think, last year I was the on-call endoscopist here in Ludwigsburg, and there was a patient with suspected Boerhaave syndrome. And I was preparing for the endoscopy and actually was preparing to do a vacuum therapy and was waiting for the anesthesiologist to get ready. We always do those procedures in general anesthesia, just to have a safe airway, especially if there's esophageal perforation. I think this is really advisable. And while waiting for the anesthesiologist to get ready, I was checking the literature on vacuum therapy for Boerhaave syndrome. And there was a lot of literature on anastomotic leakage after esophageal resection. And some studies including various etiologies of esophageal perforation, but no study that actually focused on Boerhaave syndrome. And I think it's quite a distinct etiology because a lot of inflammation going on through the cavity with infection in there. And so that's how the idea came to place. I knew Dörte was working on vacuum therapy, so I wrote her an email, and that's how the study started. Maybe Dörte, you want to summarize the study and the study findings really quick.
Yes, thanks. We included in 5 centers here in the south of Germany 57 patients from 2010 to 2023, and in these nearly 60 patients, 25 patients were treated primarily with endoscopic vacuum therapy, 15 patients with stent therapy, and 14 with surgery as primary treatment. Yes, and I think the outcome is really nameable. The treatment success of the endoscopic vacuum therapy was 80%, with a really low mortality of only 8%. And in the surgery group, the treatment success was 57%, with a mortality of 13%. And in the stenting group, the treatment success was only 27%, with a mortality of nearly 34%. So that's our results.
Yeah, thanks for summarizing. Really, I think treatment success was defined as that there was no need to change the treatment and that the patients were discharged alive. This was what we retrospectively defined as treatment success. I think, yes, these are really interesting results and a lot of patients included.
And Annie, what would you say, what is the preferred treatment for Boerhaave patients after this analysis?
Well, I think vacuum therapy is a really good treatment. Maybe I start with the stenting group, or some people, there's some anecdotal reports about clip closure, the defect. I think those are stenting or clipping or primary closure of the defect is something I would not do. Not because I think you can close the leakage, that's not the problem, but I think the problem is to control the infection on the upper side of the wall. And I think that's the great advantage of the vacuum therapy. And in my opinion, it's probably the preferred choice of treatment for many of those Boerhaave patients. Maybe not 100%, but I think for the vast majority, vacuum therapy would be my preferred treatment option. And I think the question is, do we need surgery? To what extent do we need surgery? You're a surgeon, so maybe you can give our listeners, the audience, some input on this. Do you think there's a need for big surgery, resection? Or what's the role of surgery in Boerhaave syndrome?
Yes, so I'm an endoscopical surgeon, so I'm in the same opinion like you. No, I would prefer the endoscopic vacuum therapy also, but I think there's a place for surgery, especially for sepsis control. in surgery. That means that the surgeon can place underview drainage systems into the septic focus, and then the endoscopist can control the septic focus endoluminally.
Okay, so you think if we do surgery, it's usually combined with
Yes.
endoscopy. Yes, I think that's true. So it will stay in. These will always be cases you have to discuss between endoscopists and surgeons. I think nothing you can do on your own.
Yes. But Annie, can you tell what you think? What is the main mechanism of the endoscopic vacuum therapy that provides these very good results?
I think that's probably something we just discussed. It's what we're not doing with vacuum therapy. We're not closing the leakage. That's not what we want to do. But we want to control the sepsis, and we want to clean the cavity, get all the infection out there. And I think that's what the vacuum therapy is really, really good for, to get the sepsis controlled, to get the infection controlled, and then the shrinkage of the cavity and the healing is more like I think in surgery say secondary wound healing. But this actually takes more time to get it closed, but you really control the infection. I think that's the important part in these patients.
Yeah.
Well, I think a lot of interesting findings. How would you conclude the study, Dörte?
Of course, it's a retrospective multicenter analysis with interesting focus on the Boerhaave patients, Boerhaave syndrome patients, as an interdisciplinary challenging in treatment, and the endoscopic vacuum therapy provides very good results in our analysis, and so we could prefer the first primary steps, treatment steps with the endoscopic vacuum therapy for these patients.
Yes, I think that's a good conclusion. I think it's there definitely is a place for the vacuum therapy.
Yeah, definitely.
Well, yeah. Dörte,
Thanks
for coming to Ludwigsburg for this author interview. Thank you for watching and listening. Enjoy the paper.
Enjoy the paper.
Thank you a lot.